My esteemed colleagues, I mean, some of the people here are my heroes. Some people I've known for a very long time. Trent, thank you. I'm just glad you're part of this class, man. It's good to see you. The topic is philosophically congruent chiropractic encounter notes. Why would I choose that topic? I run a company that we created chiropractic notes, electronic chiropractic notes. And so, Ayn Rand, you guys have read her treatise on what philosophy is, right? There is a philosophy or a why you do anything. And I didn't want us to just use the scraps left over from the medical profession to do our notes. So we could just use a pragmatic approach. It works, clean it up, suck it up, use it, go forward. Or let's examine it. Let's go back to the core and say, why are we taking notes to begin with? How should we take notes? And what can we do to make it congruent with what we believe the philosophy of chiropractic is? Great, right? Nobody's ever written on the topic before. So I can go to a list and say, oh, what did Dr. Kent do 20 years ago on this topic, and kind of follow his flow and use it. Nobody's ever written on this topic before that I can find. And so it's a first generation paper on this topic, and hopefully I did a good enough job. I think I did a good job. I've gotten some feedback from people I love and trust that say I did a good job. Is it complete? No, absolutely not. Is it perfect? Absolutely not. Is it done? Absolutely not. I'm going to use this to build on my ACP, my diplomat in the ACP. You guys signed up for that yet? You need to before Lyceum. So that's my plug for that. Is my 2 minutes up? Almost. So that's why I chose to write this, because number one, it's one of my businesses. And number two, I have a passion for making sure everything I do congruent with what I say I'm doing. I don't like using other people's scraps.
Great. Thank you. Gentlemen?
Well, thanks for being here.
Thank you.
Okay, we're done.
Okay. So Dwayne, I read the paper a while ago.
Yes, sir.
And then I read it again yesterday.
Yes, sir.
And I'd like to know, where do you believe the weaknesses are in this paper with respect to philosophy?
With respect to philosophy, when part of the paper was pulling out Reggie Gold's 3 paradigms. Paradigm 1 is one cause, one cure. All disease is from subluxation only, therefore we only need to worry about subluxation because it causes all disease, so it's focused on disease. Paradigm 2 is the big spectrum from the metapractor to the chiropractor, but they still are disease focused. And then paradigm 3 is the non-therapeutic objective straight from Strauss. That Reggie talks about subluxation in and of itself is detrimental to the full expression of life, and therefore it's the only reason that we need chiropractic. And the problem with this paper is we've got, in our profession, we've got people all along that spectrum practicing, and trying to find one solution for all of those, that spectrum, is going to be difficult, because those practicing in what Reggie calls the P2 metapractor, the paradigm 2 metapractor, that they don't even do adjustments. All they do is diagnose and do medical kinds of things with the chiropractic license. They need to take notes by law, and just by common sense, they need to take notes. And so their notes are going to look totally different than my notes, based upon what we do and why we do it. So that was the struggle I came up with in writing this paper, was finding out there's not one solution. They may need to stick with SOAP notes, the POMR system, and we may need to develop something different for those down here that still covers everything we need to cover when we take notes. Thank you.
You want me to go? Bill, is the crowd able to ask questions too, based on, I'm just wondering, is the interaction only with us?
Just with you for now.
Okay. So, in the beginning of your paper, you kind of established why your domain of note-taking would be under philosophy, and I think you're definitely right in
Thank you.
basically saying anything is philosophy. A nice quote in there from Ayn Rand. But, so I'm gonna ask a question. It's kind of, I don't know, maybe it's a grenade, maybe it's not, but it's interesting to me. So you talk about how chiropractors have different ways of recording notes.
Yes.
And you kind of try to establish why we should take notes at all.
Mhm.
So I'm gonna open that up and see if maybe there's questions the group will have for later, but, when you look at the people in paradigm 3
Mhm.
that would possibly use a note-taking system,
Mhm.
and how many of them, one reason you say is so that you can communicate it between chiropractors. And if you've been to 2 chiropractors' offices, you've seen 5 different ways of doing things. Is there really a good reason to take notes that would be interchangeable to another chiropractor who's probably speaking a different language? They probably don't understand your assessment. I mean, there are some small examples in small cases of some technique societies here and there, but reality is you talk about 70,000 chiropractors in the country, you've probably got, I mean, how many of them really speak in the same language? That keeping notes would really be a benefit. And isn't it only just a benefit to that chiropractor when it comes down to it?
Mostly, no. Actually, I think for that chiropractor, it's probably the least valuable to take notes. But in business, there's this, by Monday, by choice or by chance, you may not be there. Right? Who's going to take over care for your clients? So who's going to pick up the ball and run with it on Monday if you don't show up? And another chiropractor needs to know a little bit about, okay, why are you only using soft techniques for this client when you're doing Gonstead for everybody else? And that should be in your notes. Why you've been taking care of this person and they always have the same listing every week for 20 years? Maybe we need to look at something else. Otherwise, maybe chiropractic isn't appropriate for this person for that level. I think it's more for continuing care, transitioning that person onto the next phase of their life, whether it's with another chiropractor locally or in another geographic location. If they're your client, no matter how many clients you have, and they walk in, you have a memory of who they are. And they innately have a memory of who you are. This kind of goes to Andy Roberts. Last time I heard him speak was the last time he spoke at IRAPS, when he talked about the specificity of chiropractic is so specific it includes the chiropractor giving the adjustment. And so that leads to what your question really is about, is if it's different with you being the chiropractor, me being the chiropractor, why would I care what you're looking at? Just that track record so I can start with something to continue that care with the next, as they become my client. Does that answer your question, or does that open more doors?
Kinda. I don't, I've run into so many people who would look at somebody else's notes and say exactly kind of what you said. Why are you adjusting that way when clearly the evidence is that this person should be adjusted this way? And there's the alternate thinking of, hey, look, what do I need notes for? When I find a subluxation, I adjust the subluxation.
Mm-hmm.
And the one that's there is the one I'm adjusting. I don't care if your yesterday's subluxation was C5PL. Well, I care about what your
Right.
subluxation is today.
Yeah. And so and that goes to, again, it's the least important for the chiropractor that has history with it. Then the regulations for the state or whatever licensing body has authority step in, where every entity says you have to take notes, but they don't tell you how. And so we have a license is a leash, we have to do things to keep that license, and that's one of them. So yes, I agree with you. If subluxation is the thing we do, we're confident by pre and post check that we've cleared the subluxation, that's done. Next time they show up, I'm gonna do all my procedures and processes again, as if they've never been seen before. Where's the subluxation? What's the listing? What's the adjusting force I need to deliver? Offer up it as a gift for their NA to do the correction. Step away, let NA do its job. They come in next time, it's the same process and procedure, even if it is the same listing. So I agree with you there. But we're still mandated because of our license to take notes.
Thank you.
I really enjoyed this.
Thank you, Dr. Kent.
Yeah, I did, because that has always been an issue. And if we look historically, if we go back to DD, the Paradigm 1 guy who had discovered the cause of this non-hyphenated ease, and who utilized procedures like nerve tracing, which required you to identify a symptomatic body part or the ailing organ and use that as your means of determining the intervention. You know, that's paradigm one. Paradigm two is what I wanted to question you about, because
Sure.
I wonder if that's changed a little bit. In other words, I remember Reggie and talking about this, and the whole notion that, and this was kind of what the people on the other side of the fence were saying, that we're responsible for full body diagnosis, eyeballs to kneecaps, everything. And that then you determine whether or not you think chiropractic care is appropriate, and do your thing and see what kind of a clinical response you have. That seems to have shifted a little bit in recent years. We now have these people talking about how the chiropractor should be the podiatrist of the spine. Now, I've been to a podiatrist and he never looked at my testicles. He never looked in my eyes, you know, just didn't do that because no one perceived him as being responsible for anatomical regions outside. But, you know, he does have to know that if he gives you a toenail fungus medicine, it could destroy your liver, stuff like that. Yeah, he knows about that. But it's different than the notion that the chiropractor is responsible for the full body. So when I saw some of your stuff, and you know, I think this is great. I used to say, hey, the stuff I did in the olden days when I was on 3x5 cards, yes, not travel cards, I mean, the, you know, 500 for a nickel in those days kind of cards. We would record the date, the segments adjusted, and the listing.
And how much they paid.
Actually, that was on a different card.
Oh, okay.
Because I didn't handle those.
Ah, okay.
Yeah, except in the early days. So I said, this is much better than SMT to 5 areas. There's no way a person could possibly replicate that. You know, a chiropractor, if I said, you know, ASRP, most chiropractors in Paradigm 3 would certainly know what that meant. And they could replicate it. And to go to what Joe said, this is kind of interesting. I agree that we most certainly need to use the same assessment procedure pre and post. You know, that's that. And I've had students that had some real existential crises when I bring that up. That you have to have an operational definition of the subluxation, which is what criteria, what techniques, procedures are you going to use to measure those 4 elements? How do you do it?
Or in your quintessential paper,
Yeah.
you even quote Coke to go down to 2 parts. So at the bare minimum, let's
Yeah,
do the 2
in other
parts.
words, the 2-part thing is saying, you know,
Yeah.
there's a biochemical thing and there's a neurological thing.
At
At least do those. And when we came up with the practice guidelines for straight chiropractic 100 years ago and counter to Mercy, that's what we basically said. We said, you gotta have something structural, you gotta have something neurological, and we'd like at least one of them to be quantifiable.
Absolutely.
But here's the deal. Now, why do we even care? Many chiropractors don't do that.
Agreed.
In Paradigm 3, you know, they come in and they grip and rip and out the door. And if you're doing, as you said, the same thing, if you've seen that patient 40 times and nothing has changed in terms of the presentation of the subluxation, that would say to me, you know, maybe we ought to look at something else. The other thing, and this is where it gets real dicey, as you pointed out, that dreaded S in SOAP, you know, the subjective findings. And I thought it was pretty clever to say, well, let's put stuff in context. Yeah, okay. As soon as you start chasing symptoms, you're practicing medicine.
Right, and that's why I chose the context label.
Yeah.
Because if they were driving 85 and were hit by a semi last week, I'm still responsible. Let me back up one step. So
yeah.
keep that in mind.
Okay.
So there were questions in there without a question mark.
Yeah.
So the paradigm 2 shift you know, we aren't medical providers. We're not primary care providers by law. In some states we are, but in South Carolina we're not. So I was going to stick with that one. But we're our portal of entry providers everywhere. People will come to us first. And so I mentioned in there, as a human, if I see that their arm is chopped off and it's bleeding, as a human, I feel obligated that we, without any titles, need to know how to do a tourniquet, call the ambulance, and keep them alive until they tear. So there is some sort of, I need to see what's going on. I'm not saying, oh, I don't care, let me see if Atlas is subluxated. So because people come to us as their first choice after something happens, I still feel we need to be at least humane in understanding what's the context of why you're here. And then say, oh, you know what? I'm going to check you while the ambulance is coming, because this is as important as that, but they're going to take you and do the medical stuff that I also think you need, because that stuff scares me, that you told me about. So that's kind of where I think we need to be, and I think our schools are doing a great job at teaching us that. But Reggie also tells us, and we know, that the number one problem in the medical field is proper diagnosis. And they get, what, 5 to 10 times more of that than we do? And yet we want to diagnose stuff we were never trained on and don't have any skills or license to take care of. And that's where it falls apart. So I think recognizing what's ours and what's not ours is important, and I think that's where the context, changing the symptoms of what are you complaining about, I'm going to focus on that, and that's going to direct and limit what I do. To tell me what's going on, great, okay, fine, you don't need to go, we're going to do this, which we were going to do anyway, whether you smoke weed or not. So that's kind of why I tried to change that mindset about that word and that thing. So yeah, if they were hit by a semi last week on 85, I'm going to check them for subluxation. They may have it. Thoughts, traumas, toxins, right? They may have it. I'm going to check them. I'm going to say, you know what? There might be some other things going on too. You need to use your best guess. One of the things I've been blessed with is I work at a medical clinic here in Spartanburg, Regenesis Medical, and we take care of the people nobody else wants to touch. My contract with them is I don't do medical stuff, which includes vitals, which includes weights, which includes all that stuff. When they walk into my area, all I do is chiropractic, and that's all I do. And I just celebrated my 6th year with them, and they're extremely happy because I don't step on their toes, and they're busy enough taking care of their own stuff that they send me everybody. We talked a whole bunch about that too, but when we do what we say we do, everybody's happy. And I think that's where that paradigm too is too stretched.
Yeah, because I wanted to also ask you, because the symptoms thing is just eating at me, and it always has on every level. And you know, you see all the dodges, what I call the schizophrenic practice. You know, I want to do paradigm 3, but you know, people want to use their insurance, or whatever nonsense they come up with. So for them, I'll give them a CPT code. Well, yikes! You know, you've just crossed a chasm.
You've also pushed me into a very, very, very difficult area, because I know Sherman teaches CPT codes and ICD-9 codes. Y'all may not know this. You can listen in on our conversation if you want. ICD-9 is the diagnostics codes, ICD-10 now. Those are owned and copyrighted by the American Medical Association. Anything you use that produces that code, they pay a fee as a copyright to license those codes. There is no code that talks about the chiropractic subluxation. The M99s are somatic disorders or disassociations not otherwise specified. There's a reason that they're 99 codes, because what comes after 99, you have the ends. It's also musculoskeletal codes. In our definition of chiropractic, what's the MOPI? Do I find, back up, in our definition of subluxation, MOPI, where is muscle? Yeah, we're neuroskeletal experts, not musculoskeletal experts. So I have a big problem with that. And since I don't think any of those codes pertain to what I do, that makes, if I submit it on a piece of paper that gets scanned, and sent electronically across state line to an insurance company, it's fraud, it's insurance fraud, it's mail fraud, and it's a federal offense.
All true, so what do you do about that? Well, obviously.
That's my next pick, that's my next pick.
Hopefully.
I have all that tied
Well,
up next
hopefully
week in my
you're
next
not-
pick.
Hopefully you're
I'm
not
going
doing
to.
it, but if we look at this thing historically,
Mhm.
some very serious mistakes were made, as we well know. And I was talking to Dr. Rossi about this. I said the problem was, at the crossroads,
Mhm.
BJ, what am I gonna do? Talked about making it a religion, Mary Baker Eddy being model and so forth. Going scientific, because that's where the world is going. We got Edison, we got Ford, and that's the path he chose to take. And what Armand and I were talking about was, we said, you know, there should have been a third category. This isn't a religion. This isn't a subset of medicine or a substitute for medicine or an alternative to medicine. It's something else.
Separate and
It's
distinct.
not this, it's not that. But unfortunately, as you noted in the paper, when people went for insurance, all kinds of things happened. And there were several very critical turning points. One was when the Office of what they then called complementary and alternative medicine. Sure, you feel better? Okay, that'll be $40, complementary medicine. So anyway.
You know me, because I said that to Joe earlier.
Yeah. So anyway, and they said, we've got systems and we've got procedures. And systems. We got homeopathy, naturopathy, naturopathy, all the pathos things, plus acupuncture. Those are systems. Chiropractic's not a system.
No, and I think.
Chiropractic is a method.
Yes.
And that's when the slippery slope of the physical therapist becoming a doctoral level provider, having direct access and doing spinal manipulation. Yikes.
I point that out when I talk about Dr. Weed.
Yes, I saw
The
that.
PLMR,
Right.
Dr. Weed
The
was the medical
PLMR,
doctor
yeah.
that invented the problem-oriented medical record with the subset of soap notes. You guys are familiar with those, right? So he's the guy. He did it in 1961. 17 years earlier, early 50s, late 40s, B.J. Palmer called for a way of recording things so we could go back and do research. And so even in this area, B.J. was decades ahead of the medical field. I point that out, but Dr. Weed even talks about, if this only works for problems,
Yes.
this only works for diseases, this
Yeah.
does not work for wellness care.
Yeah.
But just like other books that we can mention, specifically Darwin's book, in chapter 6, he says, if this is ever found, my entire theory goes out of the window.
Yes.
That's been found, but nobody recognizes that. Same thing with Dr. Weed. He says if you use this type of thinking, this system can't work for you.
No, if there's
But
no,
we forget that part.
if there's no problem, if there's no complaint.
Yeah.
I used to have students ask me from other schools, of course, say, well, what do I do when they say, what's your chief complaint? Gotta put something down. I'd say parking, tuition, taxes,
Absolutely.
lots of options.
Dr.
Can you do
Moore,
anything about
Dr.
those?
D'Onofrio,
Yeah,
any other questions?
I have one.
Yes, sir.
What's next?
What's next is, unfortunately, I only interviewed 3 leaders in the different techniques. I know Gonstead from training from way long ago. I know Activator a little bit from way long ago. But I had a chance to sit down with Art of the Pacific. Had to sit down with, that was Sean, with Grant. I had to sit down with Rochelle Knowles.
Oh, that one.
And we had lunch at Lyceum several years ago, and I just had a chance to interview them without getting into their copyrighted stuff. And they're doing exactly what everybody else is doing. It's a PLMR, SOAP, even though we're hyper philosophical about what we do. So what I would do for next steps is go in and interview others, investigate that more. One of the appendices is about just South Carolina law.
Yeah.
I would investigate that a little bit more, because I know Illinois is different, I know California is different, and Oregon is different on what they require. So I would probably put that into some sort of a rubric to expand upon what is actually required, even though the standalone standback is whatever the colleges are teaching, which is that circular argument with CCE and SCLB and all that other stuff that we're dealing with already. So that would be next steps, but I also have in my mind a way of actually answering BJ's call to how do we codify this for research. And it's a coding system that has got technique, it's got listing, it's got where anybody can look at that, and if they go and they can figure out exactly what's going on from that one code. So that's kind of in the back of my mind. But then to expand upon it and come up with a system, a note-taking system that is truly chiropractic focused on, you came in, this is what our assessment protocols are, this is what they show. They indicate this listing, this is the adjusting force and technique, method, direction, vector, all that stuff. This is what we did, this is what we offered up, your innate to do the correction. After we gave it time to process a little bit, we did the same thing we did before to see if there's change. Great, there's change, your body's accepted the gift, starting to change and adapt towards balance, towards normal. See you next time. Whatever that next time is for your office, your protocols, and your belief system in chiropractic. So coming up with something like that that's useful, repeatable, and is helpful to everybody else, I think is something that has some value. I'm just tired of crumbs that are falling off the medical table that we tend to run around and grab as like, look what I found. And it's not good enough. It's not good enough. We're better than that.
Dr. D'Onofrio, anything?
Yeah, I just was curious, you mentioned going and doing codes.
Yes,
Is that table that you have where you categorize the different parts of
that's
what
part of it.
is that codable table?
That's part of it,
That's
yes.
part of it.
Yeah, so that's an introduction. If you look at the other tables, I even expanded upon those in the last couple of weeks just as I'm getting prepared for our conversation. There's even ways to take that 3-column system of pre, what did I offer up, post, and actually make it decipherable for research. I think one of the other things is we dropped the ball when BJ left Palmer and all of his stuff got dumped into the elevator shaft. We lost billions of dollars worth of research. We haven't, I don't know anybody that's picked it up like that. And we, as a profession, have to in our offices. And I think that's one way to do it, is if we all had some sort of usable, 9940, what does that mean in a procedure code? Anybody?
Manipulation,
Of
1 to 2 segments.
1 or 2 regions.
Regions.
So what does that mean? How can I do that for any kind of research? Is that
Okay.
cervical thoracic? Is it thoracic lumbar, lumbar pelvic, pelvic sacral, sacral coccygeal? What are the 2 segments? I don't know from this code, but that's what we grow onto because they paid. So I think it needs to be better than that. We need to do a better job of not just it's enough to be a chiropractor and only take care of our patients, our clients. Only take care of our clients. That's enough. I think we're called to do more. And I think BJ in the 50s called us to do more. And I think we can do more because you mentioned it, only 70,000 chiropractors. How many chiropractors were there 10, 20 years ago? 70,000. Why aren't we growing? Because we've stuck in our office just to take care of our own little world and not expanded to make the playing field bigger so more chiropractors have a place to grow and thrive as well. I think this is part of it to answer your question. What's next? Build upon this, have something that's usable, get more people passionate about it, see what we can do. But this is a seminal research that's not been done before. Hopefully somebody sees it in the next ACP class when you make them do papers again and says, oh, I can do that better. I'm like, go for it. Challenge accepted.
Thank you, Dr. Hoskins.